Dr. Deepa?
A very good afternoon to one and all who is connected with us today. I would like to welcome you all to the 91st CME event organized by the Continuing Medical Education Committee of the Faculty of Medicine, Bioscience and Nursing, MAHSA University. We are very happy today to have an external speaker, Dr. B. Ranjith Karthekeyan, who is a professor and head of Cardiac Anesthesia at Sri Ramachandra University, India. Today's session will be chaired by our Deputy Dean, Associate Professor Dr. Vetri Selvan. Without delay, I would like to request Prof. Vetri to introduce our speaker of the day, Dr. Ranjith Karthekeyan.
Thank you, Dr. Deepa. Good afternoon to everyone. I'm very happy to invite Prof. Ranjith Karthekeyan. He is one of the eminent speaker with us today for the CME event. So he qualified with MBBS, MD. He is the head and professor of Cardiac Anesthesia Department in Ramachandra University, Porur. He have published more than 49 research and review papers in peer-reviewed journals. He has delivered more than 204 talks in different level, the university and the national symposium and the international conferences. Also, he had examinership in different universities, including Sri Ramachandra University, KLE University, Belgaum, Bangalore. He is appointed as an examiner for MD Anesthesia in Rajiv Gandhi University of Health Sciences, Bangalore in 2013. He appointed examiner as cardiac anesthesia in KLE University, Bangalore. Also, he has appointed as an examiner of fellowship in cardiac anesthesia by Tamil Nadu Dr. MGR University, Chennai in 2019. He has appointed as an examiner for fellowship in cardiac anesthesia department by the Chettinad Health University, Chennai in 2020. Also, he appointed as a fellowship examiner in the Indian College of Cardiac Anesthesia, New Delhi in 2020. Also, he appointed as an examiner in cardiac anesthesia by National Board of Examinations, New Delhi in 2021. Such experienced and eminent person with us, Prof. Ranjith, is he have a lot of research clusters in India. With that, he published many papers. He guiding many research scholars. By the departmental invitations, he has participated by the Ganga Hospital, Coimbatore. Also invited from Savita Medical College as a guest speaker. Also invited from Singapore General Hospital as a chief or keynote speaker. Also, the AIMS All India Institute of Medical Sciences, they invited as a guest speaker. Also, he was invited from the Mahatma Gandhi Medical College, from CMC Vellore, also General Hospital in Singapore. Special appointment, he specially appointed in various universities and hospitals. We don't have enough time to read all his achievements. Without further delay, I will invite Prof. Ranjith to deliver his speech. It's a very important and valuable content. Please, Prof. Ranjith, you can deliver your talk, your today talks. Thank you.
Thank you for that introduction, Professor Vetri Selvan. Good afternoon, one and all. It is indeed a great pleasure and honor to be in this online CME. At the outset, I want to thank my good friend, Professor Sri Kumar Chakravarti, who was instrumental in me getting introduced to MAHSA University. Next, I want to thank Professor Deepa, whose meticulous planning is the backbone of the success of this CME. Finally, I want to thank Professor Vetri Selvan, without whom we could not have a MOU with MAHSA University. In the next 35 minutes, I'll just deal with history of cardiac surgery and anesthesia, how it has progressed in the last 2 decades, and what are the various surgeries which are done with cardiac surgery and anesthesia, and what are the recent advances and innovations where research can be done. Finally, before winding up, I will touch upon the top 5 challenges which I faced in cardiac surgery and the top 5 achievements of our team in the last 25 years. I'll just share the presentation. Hi all, I am Dr. Ranjith Karthekeyan, Professor and Head of Cardiac Anesthesia from Sri Ramachandra Institute of Higher Education and Research. Today I will be talking about various research options and innovations available in cardiac anesthesia. It was in year 1944. The first cardiac surgery was done. The surgery was called Blalock Tossington, and it is called the first blue baby operation. The surgeon was Blalock, and the cardiologist was Tossing. The cardiac anesthetist is missing. Cardiac anesthesia is always the man behind the screen. And the cardiac anesthetist here was Merrill Harmer. He was the father of computerized vital sign monitoring system. Always, when a surgery is done, anesthetist is behind the screen and his role is not well defined. But definitely, he is the man who can alter the outcome. 40 years later, in the year 1987, the first journal of cardiac anesthesia was issued, and the caption was, "The subspecialty speaks out." That shows the importance of cardiac anesthesia. Although it is a novel specialty, it is a very, very enterprising field. Why cardiac anesthesia is so special? You require a good understanding of the anatomy, physiology, and interventional pharmacology. If you do a slight mistake, your anatomy will be deranged, your physiology will be altered, and what was like physiology becomes a pathology. So you need to have a very good understanding of anatomy and physiology in cardiac anesthesia. Not only that, you contribute to a solution rather than keeping the symptom at bay. For example, if a patient comes with tetralogy of Fallot, if you do a proper surgery, the patient is completely cured. And the variety of work available in cardiac surgery is enormous, okay? And you have to think fast and act methodically under pressure. It is definitely an high pressure situation, but you should keep cool and do the job properly. Coming to variety, you have off-pump CABG, where you bypass the blocks in the coronary artery which causes myocardial infarction, and sometimes your valve, this is a mitral valve which is not opening, so you have to replace the valve. And another thing is children's born with congenital lesion, where you operate in the newborn period or within 1 year of age. So you have off-pump CABG, valvular replacement, and congenital cardiac surgery. Apart from that, you have vascular surgery, where the lesions in the aorta and major vascular system which supply the body, you operate. You have variety of cath lab procedures, where you use device closures or you open up a major coronary artery which is blocked. And you have lung surgery also, okay, where you deal with the lung. Here we are trying to remove a lung which is destroyed. That is called thoracic surgery. And your knowledge and your procedural skills will be tested when the patient comes for an emergency. In emergency, it is not easy to deal, okay. The patient blood pressure will be very, very low and he will be brought in an end stage condition. It is really difficult. Your knowledge will be definitely put to testing. The most common which you face with the, see, heart has 4 chambers. It is right ventricle, left ventricle, right atrium and left atrium. The most common thing which happens with an acute myocardial infarction, that means an acute heart attack, your septum, that is the chamber, the wall between the right and the left ventricle ruptures. See here you can see a small hole between the two chambers, it ruptures. So you have to take up the patient immediately and close the wall, otherwise the patient will die within 1 or 2 hours. That is the most complicated surgery when compared to left heart chamber. Here you can see a large thrombus sitting inside the right side of the heart. These are all small clots which come from the venous system of the lower part of the body and go and obstruct the heart. Now you can see the clot being removed. This is called pulmonary endarterectomy, which affects the right side of the heart. So you have one major surgery which affects the left side of the heart, one major emergency which affects the right side of the heart. These are all challenging procedures. And coming to the vascular system, the aorta, which is the blood which supplies, which is a vessel which takes the blood from the heart and pumps to the systemic circulation. Now, if a small flap happen inside the aorta like this, a small flap is created. So the amount of blood flowing will be definitely altered. So you replace with the artificial tube, and the dissection will be over. It is not very easy to do aortic dissection. And coming to the heart blood supply. See, this is a major vessel which supplies the left side of the heart, and there is a major block. You can see hardly any blood vessels getting filled up. That means the heart is not receiving any major blood supply. This type of lesions you have to open within 5 to 10 minutes. If you give a time of 20 to 30 minutes, the entire musculature of the heart is bound to struggle. And coming to emergencies are not restricted only to adult. It can be in newborn also. Here you can see a congenital aortic stenosis where the major valve which the blood comes from the heart to the vascular system was blocked. So we inserted a balloon across that vessel, across that valve, and opened it. Okay, this is a newborn arterial switch where the chambers were reversed. So we have to open across the valve, open across the septum to make the blood mixed and give the systemic circulation. Here is passing a knife. It is called the balloon atrial septostomy. Here the balloon is inflated across the septum so that the valve opens and the blood gets mixed and the patient receives adequate blood supply. And this was a case of collaterals which is called MAHSA, that is some collaterals between the right side and left side of the heart has developed, and you have to occlude in the newborn period, otherwise child can't survive, which is called embolization of the MAHSA. These are all emergencies in the newborn period. And coming to emergency can be really interesting. Here you can see a small vegetation across the aortic valve. This is a newborn child who developed vegetation immediately 28 days after birth. So this type of vegetation can go into the brain and cause an acute stroke. So you have to deal with this vegetation as early as possible. Here you can see a small umbrella-like thing in a major blood vessel which is called inferior vena cava. We place this to prevent the clot from the lower part of the body going into the heart. And this is a large tumor. This is a 28 days old infant where a large mass was seen inside the right atrium. We took for surgery immediately when diagnosed and the child became normal. These are all few quite interesting emergency which we face in cardiac anesthesia. Apart from that, we have real complex lesions. Okay, this is a pulmonary atresia in a newborn baby. The child immediately after birth, there will be no blood supply to be oxygenated. So what happens is we have to take up to the patient immediately after birth to the theatre and place a conduit between the systemic circulation and the pulmonary circulation, and the blue baby will be becoming little bit pink, and you have to do a intracardiac clipper at a status stage. And this is hypoplastic left heart. Usually, as I said, there is right chamber and left chamber. Here, the left chamber is totally not developed. This is an acute emergency. Here also, you have to go to theatre immediately and create a chamber on the left side. And the lesions obstructed. For example, it is called total anomalous pulmonary venous drainage. The venous drainage has to go to the left side. Instead of going to the left side, it goes to the right side and it gets obstructed. So we have to repathway this pulmonary vein into the left side of the heart. These are all other interesting emergencies which can happen in cardiac anesthesia. And what is more satisfying in cardiac anesthesia is you can see the hemodynamic changes before and after your intervention. Here you can see the blood pressure, which is 82/46, which is slightly on the lower side. After intervention, after grafting, you can see the blood pressure has come back to normal, 120/70. And the PA pressure, which is roughly 1/3 of your systemic pressure, the yellow one is the PA pressure, it has come down. So, you have an invasive line. Not all surgery you put all the invasive line like a arterial line or a PA catheter. In cardiac anesthesia, you have that luxury of monitoring the most invasive parameter. So, you can see the changes happening drastically with your intervention. Not only hemodynamic, you can see the echocardiogram. This was before grafting where the heart chamber is not moving great. After revascularization, you can see the heart chamber moving almost normally. Another important thing is you can directly visualize. This was during grafting where we place an octopus and the heart movement is restricted. Once grafting, this is a graft which is placed over the blocked vessel and you can see the heart moving. So, you can see the hemodynamics, you can see the echocardiogram and you can directly visualize what is happening. That is quite unique to cardiac anesthesia. And as an acute specialty, you can see the intervention immediately. As I said, this is red one is the systemic pressure and yellow one is the right side pressure. What happens? Normally this is 1/3. Now you can see it is almost equal. This was at 11:42. Then we decided to institute a mechanical device. See how much the systemic pressure has changed and the yellow one, that is the right sided pressure, has come down. So this is quite satisfying. You can see your intervention acting immediately. I'm in this field since 1998, almost 23 years of experience. So I thought to make the talk interesting, I will just go with my top 5 challenges in this 23 years. Okay, this was a Sunday afternoon where we had a newborn baby with 2 lesions. Normally, truncus arteriosus itself is very difficult and an obstructed total anomalous pulmonary venous drainage, it is equally difficult. 2 separate lesion itself is very complicated to deal with. But on a Sunday afternoon, we have a newborn baby who is 1.9 kgs and this 2 lesion was combined together, truncus with TAPVC. So that was a very challenging case and fortunate to us, it came out very well and the child has survived and it has become an adult and got married too. That was the first major challenge which I faced. This was way back in 2003. And this is quite interesting, conjunctivitis where the brain is fused at the upper end, head is fused. And what was challenging in this case, this child was posted for a cath lab procedure to see the coronary anatomy. So what was challenging in this case is, whenever you give anesthesia, one child, whatever you give drugs here, passes from this child to this child. So this child is sleeping happily and this child was always crying. So it was very difficult to anesthetize both the kid at the same time. If you give anesthesia to one kid, it passes via brain to the other kid and the other kid was sleeping. So we have to separately give anesthesia to this child. So one child was used for IV induction and another child it was used as an inhalational induction. So 2 different form of anesthesia was given to this child for a cath lab procedure. This was quite challenging. And what was another interesting series was the child weighing around 2.5 to 3 kgs. Okay, the child's hardly the child will be the size of my 2 hands, and it is around 2 kgs. These are all newborn babies. A ventricular septal defect, a large ventricular defect. Here the child weighing was around 2.4 kgs. AP window it was 1.8 kgs, and this was a slightly bigger child. We operated at an early stage in the newborn period and again at 8 years of age. And these are all complex procedures in the newborn period and all came out very well. Ventricular septal defect, hiatopulmonary window and an arterial switch undergoing a Chennai procedure. Sometimes, okay, we put invasive catheter inside the heart chamber. Okay, we introduce long cannulas inside the chamber of the heart to measure the pressure. Here the cannula was inserted into the pulmonary artery. And this pulmonary artery catheter is normally 110 centimeter, of which 40 centimeter will go inside the body and last 20 centimeter will be inside the heart chamber. What happened this? Here you can see a knot develop inside the heart and we couldn't remove the catheter outside the heart when the procedure was over and the patient was about to shift from ICU. So instead of opening and putting again it, we did a snare retrieval, which is quite difficult. Fortunate for us, it came out very well. This type of complications can happen and it is very important to deal with this situation. Your experience will come in handy to remove the knot inside the catheter. And this small guy who is a 13-year-old guy, they underwent heart transplant. This is not a regular heart transplant, okay. The child was diagnosed with what is called CTGA, where congenital corrected transposition of gate artery, and the child was dextrocardiac also. Normally the heart is on left side, okay. Here the child heart was on the right side and the vessel which we anastomosed in transplant was changed, okay, transposition, okay. The arteries which come from the heart chamber was translocated. So it was quite a difficult heart transplant and we did it successfully. It is one of the few conditions where transplant can be done, and here you can see the child playing cricket after fifth month of the transplant. That was a very satisfying case. Now coming to the part which researchers, people like you will be really interested. What are the various innovations? First is the 3D echocardiogram. Normally in 90s and 2000 we will be having a two-dimensional picture. Now we have a three-dimensional pictures, like a surgeon view of inside, okay. You can see like how you look from outside. This is very important to assess the valve as well as your ventricular contraction, like say your systolic and diastolic function, and it becomes very important during valve repair and replacement. Next is strain rate imaging. When I started my practice way back in 2000, we look heart as a whole, whether the heart is moving normally or not. Then came the systolic and diastolic function. As I said earlier, heart has 4 chambers. Then they were looking at 4 chambers, whether it is moving normally or not. Then they started looking at individually at each chamber, how it is moving. For example, if you take a left ventricle, how is the anterior wall moving, how is the posterior wall moving, how is the inferior wall, how is the lateral wall, like that they were looking. Now, they are looking at individual muscle fibers, okay. Each part, see for example, if you take the anterior wall, they divided anterior wall into various segments and look at each segments, okay. Rather than segment, they look at individual muscle fiber, how is the strain of individual muscle contracting. Not only that, they assess the blood flow to each segment. So this is a potential area for researchers, and this is Lord Hanuman opening the chest fully to prove his loyalty to Rama. This happened in millions of years ago. And after so many years, you can't break open sternum fully to do cardiac surgery. So they came the subject of minimally invasive. Rather than opening the heart fully, you open into with such small incision. You don't break open the sternum and you do a small incision, and here the cannula going into aorta, cannula going into SVC and IVC, and the surgery being done. This is really technically very difficult for the surgeon, because we used to make 10 to 12 centimeter incision in the sternum, nicely open the heart and do the surgery. But when you restrict the opening to 2 to 3 centimeters, it is going to be really tough on the part of surgeon to do the surgery. And when you do this, these are all various minimally invasive surgery. We close the heart hole with the minimally invasive or a coronary artery bypass grafting, and even we can do the valve repair. Okay, here the anesthetist role is to see that you can see a hardly 2 to 3 centimeter incision across the nipple, and this is in the lateral part of the thorax. You don't open the sternum, you open on the lateral side. Here the anesthetist role will be very important. He has to assess whether the cannula is in proper position, and you should give a proper assessment to the surgeon so that he can operate with the such small incision. the anesthetist role doesn't end here. Okay. Previously, when you used to do surgery in 2000, whenever you do surgery, we ventilate the patient for 24 hours. The next day morning, for example, if you do the surgery at 8 o'clock on Monday, you will extubate the patient on next day morning 8 o'clock when everything is okay. By doing this minimal surgery, this is avoided. What we do is we give nice regional block. Previously, regional block was not given because we used to anticoagulate the patient and we thought that lot of spinal hematoma can happen and we don't give regional anesthesia. But nowadays, we go for lesser invasive with ultrasound, we exactly locate the nerves to be blocked and we give small amount of local anesthesia and give nice regional anesthesia. So the patient is comfortable and you extubate the patient immediately after surgery. Not you shift to ICU, wait for 24 hours and extubate. We extubate the patient immediately. So patient comes to ICU for 1 day for observation. The second or third day when patient is absolutely normal, the patient will be shifted to home. So what was like 10 to 12 days ordeal in hospital now reduced to 2 to 3 days if everything goes on well. Your minimally invasive surgery and fast tracking anesthesia made cardiac surgery picture totally attractive and with very excellent outcomes. And coming to the monitoring part, previously we look only at the blood pressure. Now you can see with the advanced monitoring system, blood pressure has gone to one corner. This looks like a calendar where you have times, hours, seconds, milliseconds, years, month, date. So previously only one parameter will be there, 130/80, systolic and diastolic pressure. Now you have so many parameters which can definitely make a very good outcome. Here you have cardiac index, you can measure the cardiac output, you have the stroke volume, that is the amount of blood coming from the heart, your systemic vascular resistance, the resistance which the heart faces when the blood is ejected out of the heart, your stroke volume variation, each time how much the stroke volume is varied, and you look at various lung parameters and the volume parameters inside the heart, the global end diastolic volume, which means the amount of blood which is present inside the heart at the end diastole, and you can look at systolic volume also. And ejection fraction, global ejection fraction, which was a parameter which was monitored by echo, now you can look with invasive hemodynamic monitor, various parameters which can be derived from invasive monitoring, and you can look at the pulmonary vascular resistance index. So many variables are there. So why you need so many variables? See, when you treat a blood pressure, this is you treat randomly. But if you look at these parameters, which parameter like a volume is important or a resistance is important or your pressure is altered, whichever is altered, you can deal that with separately. And various pharmacological agents are now available which can treat these parameters separately and your outcomes are really excellent. This is another very good area for research. So many invasive hemodynamic parameters are there which is available for research. And this parameter is not only available invasively, now non-invasive cardiac output parameters are available. So not necessarily you have to put a cannula inside the heart and then only monitor. Now you can just place a probe over the finger and you can get all the parameters for treating. And as I said earlier, during cardiac surgery, we have to give anticoagulants so that the blood does not coagulate. So the surgeon can do the surgery. By doing this, we are making the patient at risk for bleeding. Previously, when bleeding happens, we used to give blood as a whole and try to control the hemorrhage. The coagulation system has about 14 factors and each parameters can be altered. Not only coagulation factor is important like WBC, platelets and various other cells also might be altered when you give anticoagulants during cardiac surgery. By doing this point of care coagulation assay, we know exactly which coagulation parameter like platelet is causing the damage or factor 7 is causing the damage, which factor is responsible for bleeding. You know that factor is altered and you try to give that particular factor instead of giving blood as a whole or plasma as a whole. So concentrated factors have come into picture and you give that particular factor to control the bleeding. This is another very interesting area of research. And another important thing is ultrasound guided procedure. Previously, this is the jugular and this is the carotid artery. You can nicely see the big jugular vein which is inside in the neck, and you put the catheter inside the heart chamber through this vein only. Okay, this is a carotid artery. We usually, before 2010, before ultrasound came into picture, we blindly put into this chamber. But now we have you can see the needle from the skin goes inside the vein, okay, and this guides into the heart chamber. So there is a direct visualization. Ultrasound has made the procedures really simple and without complication. For example, this is a vein. If you put the cannula inside the carotid artery, it is going to cause a big hematoma, and you are going to cause an anticoagulation in the perioperative period, and this hematoma might expand, and sometimes this hematoma might compromise the blood supply to the brain. So these complications can be avoided when you have a direct visualization through ultrasound when you place an invasive lines. And we were talking only about echocardiogram. Now, the magnetic resonance imaging and computer tomography has come in a big way. So, all your diagnosis, even small vascular structures like MAPCAs or small pulmonary arteries, can be easily visualized with accurate assessment. Measurement is very important. For example, when you are doing BT shunt, you have to assess the size of the pulmonary artery. See, the pulmonary artery might be hardly 2 millimeter or 3 millimeter. So, you have to decide the graft size based upon your pulmonary artery. So, this type of small minute measurement have become possible with CT imaging and MRI, and these factors have made a very big impact in the outcome. And coming to the left ventricular assist device, now everybody with COVID are talking about Ecmo. They are basically a mechanical device which supports the heart and the lung. Okay, you give rest to heart, you place a cannula inside the left ventricle and take the blood from the left ventricle and pump into the aorta. So the purpose of the heart is altered. In Ecmo, you need oxygenation. So the lung part, so you need a extracorporeal membrane oxygenator. That is the Ecmo is nothing but extracorporeal membrane oxygenator. The oxygen purpose, the lung is bypassed and oxygen is being provided to the body. So this mechanical device made the end-stage heart failure and lung failure treatment very easy, and the outcomes are really good nowadays. And another important thing is biventricular pacing. You pace the one catheter in the right ventricle, another catheter goes into the left ventricle, and the third catheter goes into the right atrium. So you have atrial biventricular pacing. Normally the conduction system comes from the atrium and goes into the ventricle. So you are trying to replicate the same thing by putting one catheter into the atrium and two catheter into the ventricle. This is called atriobiventricular pacing, which resembles the normal conduction system of the heart. It is like a normal intrinsic pacemaker. This becomes very important in advanced stage of heart failure. You get the normal rhythm going. And this is another very fascinating field of research, which is called ischemic preconditioning. What you try to do is you occlude the blood supply to the heart. This is the major vessel of major blood supply to the heart, which is called left anterior descending. What you try to do is you occlude this vessel and see how the heart reacts, whether the heart contraction is coming down, and you look at the ECG where your ST elevations or something is happening. By doing this, what you are doing is you are preconditioning the heart to insult. You are cutting the blood supply and preparing the heart so that when a major insult happens, the heart withstands the insult better. You cut the blood supply for 2 minutes and see how the heart reacts. So next time when the heart blood supply is cut for 3 or 4 minutes, the heart will automatically send the messengers so that it reacts to the insult. This is called preconditioning. Now, various pharmacological agents, rather than occluding the vessels like this, various pharmacological agents like volatile anesthetics are help to precondition the heart, which helps the heart to reduce the infarct size and to react better when an insult happens. Another important thing is stem cell therapy. They collect the stem cell from various parts and inject into the damaged part of the heart. Here you can see the stem cell being injected into the damaged muscle part of the heart, and this helps in improvement in ventricular volume, infarct size and your left ventricle contractility. So, stem cell therapy is another important prospect for research. And being our unit is one of the oldest unit in India, it is almost, it was established way back in 1994. So, we have about 27 years of experience. We have crossed about 25,000 cases and we have done the entire spectrum of cardiac surgery which was available from a Norwood procedure to complex transplant in 80-year-old. And proud to say that we did the country's first LVAD way back in 1999. This is a first generation LVAD. Now third generation LVAD is seen. Here you can see the patient sitting comfortably in corridor with the artificial heart, and this gentleman underwent transplant 2 weeks later and everything went off well. So I am proud to say that I am a part of country's first LVAD in 1999. Then we implanted Impeller is now become a regular left ventricular assist device. We implanted 2 Impeller. This was one of the first in the country way back in 2008. What does the Impeller do? It takes the blood from the left ventricle and pump into the aorta. It's reasonably a very good left ventricular assist device, and very happy to say that we started it first in 2008. And Tavi, transcatheter aortic valve implantation. Now everybody knows Tavi is being done for aortic valve stenosis, which is the main valve from which the blood comes out of the heart and goes into the aorta. And what is different here? Now a lot of people do Tavi, but usually you go from the lower end of the body and place the aortic valve. Here the patient had femoral artery disease and you couldn't go from the lower end. So what we did is we opened the sternum and introduced the valve through the aorta. So this was a transcatheter aortic valve implantation via transaortic route. It is not the transfemoral route. So this was one of the first procedure which we did. And another thing is the first successful neonatal Ecmo. Okay, this baby was born with respiratory distress. It was a 2.3. Here you can see the child being awake. 2.3 kg baby, where he inserted a neonatal Ecmo, and it was successful. The child did really well, and it was very satisfying to see a newborn baby surviving after Ecmo. And another important achievement which we did was doing 3 transplants in a span of 36 hours. Okay, we did 3 transplants and all came out very well. That was quite a unique achievement. And we had the country's smallest pacemaker placed in an 87-year-old. Here you can see a small capsule-like thing. Okay, the pacemaker. The procedure looks complex, but you can see a small this capsule-like thing. This is a usually pacemaker comes as a very big box, but this was a very small capsule-like thing, which is like an pacemaker, and we were the first to do in South India. This was quite new procedure, and it is coming in a very big way nowadays. So to summarize, cardiac anesthesia gives you excellent opportunity for real-term learning with respect to procedure skills. You have to be really highly skilled, and your cardiovascular physiology, fluid resuscitation, anesthetic management, and wealth of information from the monitoring system and a clinical decision on a minute-to-minute basis. A small wrong decision which you make will cause patient his life. And cardiac anesthesia can totally change your perspective as a resident after you finish. All of a sudden, sick patients and complex cases aren't nearly as dangerous as they were once. This is Lord Vinayaka. I really admire this animation. This was made by me. What is so unique about Lord Vinayaka is each part of his body has some message for the anesthesiologist. Small eye to concentrate really hard, small mouth to talk less and work more, and trunk, which is like an TE probe, which is a weapon for any cardiac anesthesiologist to work with high efficiency and adaptability. All hallmarks are required for a cardiac anesthesiologist. So everybody selects a profession which is very close to heart. But in cardiac anesthesia, you are not only close with, you deal with the heart. And you cover all specialty of anesthesia like pain, critical care, transplant, regional anesthesia in one go. Thank you.
Prof. Vetri, you have not muted your microphones.
Yes, thank you, Dr. Deepa. Prof. Prof. Ranjith.
Yeah.
Prof, excellent talk on cardiac anesthesia is very informative for all those who are attended in these sessions. Really, it's a wonderful talk. I have to say a few things. Mainly, you had attended more than 25 cases, isn't it, Prof?
25,000.
25,000 cases. So you had vast experience on cardiac anesthesia and surgery. So minimum invasive techniques, different instrumental techniques. So we learned many things. So the audience have many questions on your session, Prof. Shall I ask one by one, Prof?
Yeah, sure, definitely.
Okay. It's a excellent information. Many of the participants there commented on your presentation. Also, one of the question is cardiac anesthesia is the only super specialty where you can actually can become director of program. So this is they wanted to say something on your presentation, Prof. Actually, they are all very happy to say something on your presentation. Also, thank you.
One more question is there.
Prof, sorry to interrupt. There's one question from Prof. Sri Kumar. He's just asking you, if you occluded the LAD, will it not cause more ischemia and damage?
That is what ischemic preconditioning is all about. So what we do is we occlude the vessel, we look at the ST changes, we look at the heart. Okay, until the damage develops, we will give a period of around 2 to 3 minutes to see whether ST goes up or any echo changes happen. Okay, if that doesn't happen, that means the heart will withstand. If some changes are happening or something, immediately we will release the ischemia and we will put a shunt inside and we will do the surgery. This type of preconditioning, what happens is when some damage happens, okay, you are making the heart to withstand insult before, so that when one bigger insult comes, the heart will withstand it better. That is the main logic behind it. Suddenly when pressure comes down or something, this type of ischemic preconditioning won't cause an infarct. It might reduce the blood supply, but it won't affect the heart muscle because you have stimulated the heart already to withstand that insult. So even if some hypotension or some ischemia happens, the heart will withstand better to that damages. That is, but you should be very careful. You see, you should only induce ischemia for 2 or 3 minutes. That duration is very, very important. If the lesion is very tight and if you induce ischemia for 2 to 3 minutes, then it might totally damage your heart muscle. So with the experience, you will exactly know how much time you can induce that preconditioning for the heart. That is very important. And it definitely helps with the insult of the heart. It will have
Prof,
a better outcome.
I have one question, Prof. For the geriatric patients, what are the challenges during cardiac anesthesia, Prof?
See, geriatric patient, first of all, they will be edentulous. They won't have any teeth or anything. So maintaining airway itself, start from giving anesthesia will be a problem. Okay, then cannulating each vessels, all the veins will be tortuous. So getting a cannula itself will be difficult. and the vessels will be calcified. So cannulating a radial artery or anything, that also will be very, very tough. And most of the time the aorta will be diseased. So if you need a mechanical device to put through femoral artery or something, there might be a lot of calcium inside. So if you put something, the calcium might go as an emboli and cause brain cerebral emboli. So pediatric and geriatric in both way are very similar. You have to be handled very carefully. Both are very similar. If an young adult comes, it is more easy to manage. But with that, I will say that nowadays, lot of young patients in the 30s and 40s are coming with the heart attack. So the surgery, most of the patients, now 70% of the patients are in 30s and 40s. When I started my practice way back in 2000, it will be 60s and 70s. 67, actually 60 years is luxury for us. If a patient with 60 years comes, okay, he's an young guy. But nowadays, we are seeing patients with 30 to 40 years. That is very, very bad. And what is another important thing is the vessels in these young individuals are badly diseased so that surgery can't be done. That is another important issue. So lot of environmental factors are affecting the coronary. See, previously the coronary lumen will be around 4 millimeter or 5 millimeter. Now it is hardly 1.5 or 2 millimeter. Imagine surgeon's plight. Fortunately, we have a very good surgeon who does beating heart very well. But imagine the plight an upcoming surgeon or who are not well versed with beating heart or something. It is very difficult to manage. So the surgery, the cardiac anesthesia is always dependent upon the surgery. If you have a very good surgery, you can experiment with those things. But if the surgeon is a little bit learning or not much experience or something, you have to manage accordingly. You should shift your practice accordingly to make the surgeon happy. That is very important. I
Thank
was
you.
lucky in that aspect. I worked with one of the greatest surgeons. I worked with around 3 or 4 surgeons. All surgeons are really excellent surgeons. So I could experiment with so many things.
Thank you so much, Prof.
Yeah.
Thank you. Any others? Dr. Deepa, do you have any questions?
Prof, thank you so much for that informative talk and the challenges that's being faced and how to overcome. Is there, I mean, when you're talking about research focus, right? Do you have any national priorities, like as far as India is concerned? Do they set priorities and they encourage on this set of research as far as cardiac surgery is concerned? And how is the priority setting made national wide in our country there?
See, when COVID was at rampant stage, Ecmo was a very big issue. Ecmo was put on every. At the time, who was supposed to put the Ecmo? Intensivist, a cardiac surgeon, like that it was there. But a cardiac surgeon dealing with any assist device, I will advise cardiac surgeons are the best to deal with mechanical devices. Might be cardiologist or sometime, but definitely the invasive things like mechanical devices and other things should be done by surgeons, ably supported by cardiologists and cardiac anesthetists. Otherwise, specific guidelines on certain things. See, cardiac surgery is very unique. You don't know which patient will give trouble, which patient. You can't have a preferred set of guidelines. For example, if it is an off gap, suddenly you might have to put on pump. So whatever guidelines you put on off pump, suddenly will change to on pump. So you can't have a preferred set of guidelines and protocol for each patient. It should be individualized. Depending on that patient and your experience as a surgeon and anesthesiologist will help rather than formulating a guidelines and dealing according to the guidelines for that patient. That is very important.
Okay. So
Thank
that
you.
is
Being
a
a
Thank you.
microbiologist like that, you can have a particular antibiotic for that case, but here it will different. See, for example, when you have developed a post-op some pneumonia or something, we have to send the culture, get the culture sensitivity positive, then only we have to change the antibiotic. But see, when the infection happens after that, dealing will be very difficult. So what surgeon will be doing is, he will prophylactically go very aggressively antibiotic, even though the culture is not come or something. They will try to hit hard, because once after infection sets in, such a big sternum and you are dealing with the heart, he won't take chance. He will always prefer to have an prophylactic antibiotic. So at the time, guidelines might say only 2 days antibiotic or don't give antibiotic or something. So it is the surgeon's decision which matters most rather than an protocol-based guidelines or national policy or anything. Hope
Prof.
you understood what I'm trying to
yeah.
say.
Everybody
Yeah,
understand,
thank
Prof. Is very
Yeah.
clear. So, Prof, I have one more question. So, for the student aspects, for especially for the medical students, what the student have to learn which is very important for the aspects of anesthesia, because they have posting of anesthesia. So which area they have to focus on their studies during
That is
year
the
3, year 4, year 5.
that is
This
the
is
reason I
very
put
important
that.
for our medical students, Prof.
Can I, Morgan? Can you share that Vinayagar picture, Morgan?
So this is very helpful for our medical students.
Morgan, Morgan, can you share the Vinayagar picture?
It's already in the live, sir.
Yeah, you can.
They can share.
Madam, can you show that Vinayagar picture, ma'am? The last slide. I think Deepa madam has to show it. I think. Is it possible? The last part of the presentation.
Hi all, I am Dr.
Last
Ranjith
one.
Karthekeyan, Professor and Head of Cardiac Anesthesia from Sri Ramachandra Institute of Higher Education and Research.
You need to go to the last part, ma'am. Okay. See, what you need is definite hard working. Okay. There is no. You can share, Morgan.
Talking about various research options and innovation.
Morgan, minimize the screen, Morgan.
Prof, in the streaming, Prof, it's difficult to move like that. We cannot show the last part, so it's not.
Okay.
It's difficult to.
Okay, yeah, sure, ma'am. It's okay, fine.
Yeah.
If at all message is definitely you need hard working, ma'am, and your knowledge should be really good in basic science, anatomy, physiology, and pharmacology, and in fact microbiology also. You should be very strong. A small mistake which we do, but the surgeon might have worked very hard for 5-6 hours. Okay, one small mistake which we do might finish off the whole hard work put by the entire team. So you can't afford to do any mistake. That you will learn with the experience. Definitely, it is very, very important. You can't afford to do a single mistake. Next, your knowledge. You should not be superficial. Your knowledge should be really deep. You should understand if you give a drug, what does drug do to the body and what are the side effects. Everything. You can't just, if pressure is low, just give inotrope or something. You should not do. You should have a good knowledge what this drug do. Particularly, see, in a healthy individual, it is okay. But in cardiac surgery, the patient might already have an MI or some valvular lesion or something. So all the metabolism will be deranged. For example, a renal failure patient is coming for a cardiac surgery. Immediately, you have to alter the drug and everything. So it is really, but one thing is, it will be really challenging. But if you save one life, it gives immense satisfaction. And most important thing is the surgeon won't see, unless you are very good, the surgeon won't take you because he is doing so much hard work. And if you do a small decision and the outcome is bad, definitely he won't like you. So it is very, very important. Fortunately, in that way, our surgeon was very understanding and we form a good wavelength and we are going on well. If at all any message for the student, your basic knowledge should be good. You should work hard. With experience, you will learn everything. That is the key goal. And you have to stick to cardiac anesthesia. You should not learn and leave to go to general side.
There's one question, he's asking, sir, tell us about the future prospects of cardiac anesthesia.
Now with the robots coming into picture where robots can do intubation, really, I don't know what is the future. In 2020, 2050, it is going to be very, very difficult. Okay, now everything is so technologically advanced. Whether anesthesiologist has to stay at the head end, I don't know. He will be monitoring remotely from his room or something, which most of the anesthetists do nowadays. They can monitor through a LAN system what happens inside the ICU and everything. So definitely future. I never expected that we can extubate patient on table in 2000. By 2020, we are treating like it is like a normal surgery. So by 2020, 2040, I really don't know how it will change. Might be once my kids get into medical college, they will answer this question. It will change. I don't know.
Yeah. Prof, there's another question from Dr. S.M. Suresh Babu. Sir, for cardiac patient undergoing non-cardiac surgery, is there evidence to suggest cardiac anesthetist makes a difference in outcome? I mean, yeah.
Okay. As my professor, Professor Vijayalakshmi Kamath and Professor Mahesh Makamudi, they always say that one word. Okay. It is not the anesthesia which makes a difference. It is the anesthesiologist who makes the difference. Okay. Whatever you give drug or give something, it doesn't make the difference. But the anesthesiologist who give the drug and knows what is happening will definitely make a difference. But there is nothing called non-cardiac or cardiac. See, anything. See, cardiac anesthesia, you are in luxury. I can get all the monitors, I can get the echo probe, I can ask the surgeon to put a LVAD and everything. But non-cardiac, it is very, very difficult. All they have is one NIBP, one pulse oximeter, one ECG, and they manage a case. So here I have the luxury of viewing everything and doing the case. In non-cardiac, I just going to have non-invasive monitoring and I have to manage the same patient which is coming, and we are not doing intervention to correct the procedure. We are doing an intervention for a different procedure. So hats off to non-cardiac anesthetist. In that case, I will say an experienced non-cardiac anesthetist is far, far better than cardiac anesthetist. I can tell with bold letter because I am seeing everything I can manage, but they are not seeing anything, but they are managing. So it is totally different. Non-cardiac anesthetist is far, far better in managing a case for non-cardiac surgery. But when
definitely that makes a difference, right? He's asking, does it make a difference in the outcome? So definitely.
See, that is what I'm telling. Cardiac anesthesia is usually bound to luxury. When I go to manage a case, immediately I'll put an arterial line, I'll put a CVP, I will have the inotrope ready. But that is not the case with non-cardiac anesthetists. They will know what to do. It is a different practice altogether, man. So you can't compare like that. If a non-cardiac anesthetist manages case, it will good. Cardiac anesthetist manages a case, it will be good. It definitely you should not compare like that. See, you can't say an off-pump beating surgeon with the guy who is doing a surgery on pump. Both have their own protocols and own things. So you should not compare a cardiac anesthetist with a non-cardiac anesthetist. Might be if they don't get a line or it is really difficult line, we can get the line. But managing the case, both will have the same knowledge and both will be the same. That's what I think. In fact, a non-cardiac anesthetist will be far better.
Thank you, Prof. I think there are a lot of people commenting here. Like, I think it's one of your team members, Dr. Sri Jayanti Krishnaswamy.
Dr. Sri Jayanti is one of our senior most professionals of our country.
Okay, very proud to be part of your team, and we are very happy to have you here. Actually, this is one of our professors. I think good presentation highlighting critical cases.
Dr.
Bala Baskar.
Yeah, he is a former ISA president and he is former editor of Indian Journal of Anesthesia. Very towering figure in non-cardiac anesthesia. He's like a guru. He's very good.
Yeah, good to have him here. And I think we have our professor, I think he's orthopedician, Professor Razif Ali. Thank you. Cardiac anesthesia is a very specialized field to ensure safety of surgery and good long-term patient recovery. Yeah, that's from our professor from MAHSA. And many of them have told it's an excellent presentation, very informative, and I think we will stop here. Thank you so much, Prof. Thank you so much, and we are very privileged to have you here today with the CME committee, and I hope to have many more events in future. I wish that you will stay connected with us.
Sure, ma'am. Definitely.
Anytime. Thank you so much.
Thank you, Prof. Thank you, Dr. Deepa. Thank you.
Thank you, Prof. Vetri, for sharing the session, having time. I think I just told him a couple of minutes before the event, and thank you for that. And Prof. Rusli actually asked me to convey his regards to you, and he wasn't able to make it up, and as well as Prof. Sri Kumar. The committee would like to thank Prof. Sri Kumar for actually introducing you to bring you in for a CME event, and we wish to have many more events with you, Prof. And sharing your knowledge, it'll be great. I mean, the next event, I think we will organize it for our students, like our clinical year students as well, so that
already Vetri was telling about that.
Yeah. We will arrange with the clinical years and the preclinical years. Just
sure, we'll do that. Yeah. If you want something about e-learning, we'll do that.
Yeah. Sure. Thank you so much, Prof. Ranjith and Prof. Vetri. Thank you.
Thank you very much.
Thank you. So with that, we come to the end of today's CME event, the 91st CME event, and it was really nice to have an external speaker, Prof. Ranjith, Thank you all who attended. I know many of our colleagues are with different meetings, and I hope they all will watch it offline later. So usually our watches go beyond 100. So that is expected with all our CME events. And thank you, those who got connected with us live today. And I would like to remind all of you to mark your attendance for your CPD points. Thank you once again to all of you who joined us today, and hope to meet you all in the next CME event. Thank you and have a good day, all of you. Thanks.